that Chelsea is joining us, and I wrote something to introduce her, but don't have it in front of my face, which is silly. But I sent it to you, Chelsea. So let me find it real quick. So I just want to take a moment before we get started, to just express my gratitude to Chelsea for being here today, for talking to me before this so that we could work it out, and the time that she's giving us today to talk about this. Showing up to share your story in this space, as we all know, it takes a lot of courage, and this journey leaves marks on all of us. So opening up about this is not a small thing, and I really am grateful to Chelsea that you're joining us today. Chelsea comes to us today as both a DSRCT caregiver and as a palliative care nurse. And that combination of lived experience and professional wisdom is exactly why I wanted to share her voice with us with you guys in this space. I do want to note that Chelsea is not here to offer medical advice or guidance specific to any medical situation. She's here to share her own story and her professional perspective as someone who's worked in palliative care. And as we all know, every patient's journey is unique. So take what resonates, hold it gently, and as always, please direct any specific medical questions to your medical team. But I'm just going to open the floor up for Chelsea to tell us her story. And then after she's finished, I think she's going to give us a few minutes to ask her some questions, right?
Yeah, absolutely. Can you guys hear me okay? Okay, good. So as Laura said, my name's Chelsea. I live in southern Missouri. So we have lived here as long as I've been alive. And this is where I've had all of my nursing experience. The perspective as a nurse and a caregiver is one that is really interesting and unique. And it's been, honestly, pretty difficult to navigate. Just my personal background. So I have been a nurse for 15 years, working primarily in medical ICU. And then I taught at university for a couple of years, and now I do palliative care. And the person that I'm going to be talking about today is the father of my children. His name is Robert. So sometimes as a nurse, I feel like I can get pretty clinical, like when I talk about patients. So I'll be a lot more personable later, but as I talk about the timeline, it's almost like a dissociation with it and just talking about it like it's somebody else. So I made notes because I am pretty nervous. This has definitely profoundly affected me and Robert and our children. So we're going to go all the way back to September of 2012. At that time, Robert was 29 and I was 25. Robert presented to his doctor's office with some vague abdominal pain. One of his coworkers jokingly tapped him in the belly and it doubled him over in pain. And I was like, that doesn't sound right. So they scanned him and a CT showed a large softball-sized tumor in his abdomen, and he had an XFLAP with cytoreduction. When the surgeon came out to talk to me after the surgery, because we didn't know what to do, we just knew there was something in there and we needed to get it out. When he came out, he said, we got a really large tumor out of Robert, but we were not able to get everything because there were, and he said, and I quote, innumerable peritoneal studding throughout his peritoneum. So all those little baby clumps of cells, just tons of them, almost like a satellite when you look at nighttime when it's here's all the lights. It was very much like that, just lit up his entire abdomen. So after that, and it's also very ironic and not lost on me that he was diagnosed in September. Happy Childhood Cancer Awareness Month. He was diagnosed with DSRCT, port was placed, and we started P6 protocol. 2 weeks before Robert was diagnosed, I found out that I was pregnant with our youngest child, Josiah. So we had already had Kyson, who was about 1.5, and then I was newly pregnant with Kyson, or with Josiah. So that was a lot to kind of navigate. So in April of 2013, Josiah, my youngest, was born, and we continued doing treatment as diligently as we could. In October of 2013, the P6 protocol was over, scans were stable. He did have 2 small nodules that were noted in his abdomen, but they never grew, they never shrunk, they were just there. In the summer of 2014, we went to Barnes and had a stem cell harvest completed. And then in September, again, in 2014, Robert recurred with pretty significant abdominal disease and started chemotherapy. In December of 2014, we traveled to Charlotte, North Carolina to meet Dr. Pete Anderson. And that was when he was working at Levine. And I know that Cole had been there, and I actually met Laura in person when we went there. But as soon, like probably about an hour outside of Charlotte, and we drove from Missouri all the way to Charlotte, about 40 miles outside of Charlotte, we received a phone call that we were planning on doing HIPEC, but the surgeons were not going to be able to do HIPEC. So just to kind of put that into like perspective, at this point, this is 2014, I have Kyson was 3, Josiah was 1. We plan to go across the country to have HIPEC. So we had to find childcare, you know, for our kids and make sure that they were taken care of. Also, the financial implications of taking at least a month off of work is significant. So just to put that in perspective, we really had put like all of our hopes and dreams into getting this HIPEC and went to Charlotte, and it didn't end up being able to happen. There are a couple of reasons why it didn't happen. One of which is that Dr. Anderson had some disagreements, I guess, with administration of hospitals. As somebody who's been in healthcare for a long time, I mean, a lot of times you can see things differently. And he decided that it was time for him to resign. So we did not have a sarcoma specialist that would help us on the other side. So we had a willing surgeon, but we didn't have any medical person that was like, oh yeah, like let's do this. So we turned around after a couple of days and came home really devastated, if I'm being honest, because, you know, at that time, HIPEC really was built up in my mind as like the be all end all. Like, we've got to get it done, and it doesn't matter how we do it. And we weren't able to accomplish that. So we came back to Southern Missouri and we're doing chemo again. Then that next year, so that would have been in January 2015, we were able to meet with Dr. Anderson face-to-face in the Cleveland Clinic, and we're able to plan for HIPEC. So HIPEC, like, I mean, if you think about it, like, why didn't we do it at Cleveland Clinic? Part of the reason we didn't do it at Cleveland Clinic is because we live in Southern Missouri. That's quite a distance to go away from my kids, and I had already chosen to like do that before and made all the arrangements and everything. And I was like, we've got to do this more locally if we can. So we were able to talk with Dr. Jula Virapong at St. Louis University, and he did Robert's HIPEC. So when he did Robert's HIPEC surgery, he also had a GJ tube for nutrition. So just to put that back in perspective with the whole family, when Robert had HIPEC in February, Kyson was 5, Josiah was almost 3, Robert was 32, and I was, 27? So it was a significant time in our lives, and it affected our entire family. So after we ended up having, we had the surgery, Robert ended up getting a pretty severe pressure injury under his gastric tube. And so we had to wait quite a while for whole abdominal radiation. However, he completed that whole abdominal radiation in April of 2015 and was rescanned, of course, 3 months later, and was declared NED and has been since that time. Yeah. So 11 years almost that he's been completely NED. You know, our story has affected our family in a lot of ways. And when I was talking about the whole abdominal radiation, you know, one thing, Laura, you and I hadn't even talked about is my sister is a radiation therapist. My sister treated Robert. And at the very end of Robert's treatment, we were really concerned that Robert was going to pass away because he had lost so much weight. And my sister told me, and you know, she sees a lot of patients, and she said he looked at me and he just really didn't have any fight. Like he really was like, his eyes were just blank. And so that has affected us in ways that I never even really considered, right? Because it's not the people that live in my home. But this journey can do to change people. So I made a couple different categories of the areas where we had a lot of issues when Robert was in treatment, you know, after diagnosis. And, you know, when Laura asked me if I wanted to come and speak with you guys, it wasn't that I'm so distant from DSRCT. And yeah, you know, Robert's a, you know, 10-year, 11-year survivor without any treatment, and he's doing great. And so it doesn't matter about those people. Mostly I wanted to be able to sit here and honestly tell you how this disease has affected our lives. And when I started thinking about everything that happened, it almost was like a re-traumatization of, you know, wow, like we went through this entire thing. I haven't really thought hard about it for a while, but just thinking about the effects that it's had on all of us is really significant and really important. So, of course, when somebody is diagnosed with a serious illness and things that are definitely going to change things around, one of the biggest things that affected us at first, there was a huge financial implication. So Robert was a phlebotomist at the hospital. Well, all of you that either have gone through treatment or have loved ones who have know that being in a hospital is like the worst place that you could be because everybody's sick. And so he was unable to work. And so I was working 4-5 nights a week in the ICU while pregnant, and then with like a newborn and nursing, and with our, you know, toddler. And so that was a huge weight that we had. And then that was like the initial push. And then when it was coming time to have a second opinion or surgeries or things like that, there's help, of course, for things like that, but there is a financial burden on trying to find a place to stay and trying to figure out how, you know, you're gonna have your dog cared for or whatever it is. Like there's just a lot to think about. And so initially that was the biggest thing that I noticed. I don't know if anybody here has kids, but the way that DSRCT has affected my children is life altering. And like, I don't want to mince words about that because now Kyson is 14 and Josiah is 12. So when Robert had HIPEC in St. Louis, we stayed in St. Louis for almost a month. I tried to go back and forth as much as I could to see the kids. They really could not come and see Robert. I mean, it was really difficult. And at that time, Josiah was 3 and Kyson was 5. And so they really didn't have the ability to really understand what was going on, nor did I really have the capability of explaining, like, in a age-appropriate way, what was happening. Robert really became different in front of them. You know, at first he just had like a little scar on like his midline around his belly, and then it was an even bigger scar, and then he had a port, and then he ended up having to get another port, and so he just completely changed into a different looking person. He after the whole abdominal radiation, he got very thin, and he was on tube feeding because of the irinotecan, and the side effects from that make you run to the can. And so he lost, I would say probably within a month and a half, truthfully, he lost about 50 pounds, just like that. And he is a strong, like big, stocky football player kind of guy, you know, and just to see him completely look so different, I'm sure that it was terrifying for the kids. My kids have really struggled with their mental health. There's a lot of research about trauma in children, and it's really difficult because I would walk through fire to make sure that things don't affect my children. I would take all of that on, and unfortunately, they're kind of like the bystanders in this like situation. And so we engaged therapy very early. My kids started therapy very early, and they both see psychiatrists because we've had them psychologically evaluated. My oldest has autism, but he also has severe depression and anxiety. And then my youngest, Josiah, because he kind of was little and like a toddler during like this very unsettling time, and like he really has an adjustment disorder and difficulty with oppositional defiance disorder. And I mean, those are real things that have happened. Can I say 100% that they're attributed to DSRCT? Absolutely not. But I can tell you the research does show that trauma in childhood, it definitely changes the way that your brain is functioning. And unfortunately, there's not a lot that we can do for that except for try to support them. Robert, he is now 44. He was able, after he got cleared NED and all of that, he was able to go back to work. He worked in corrections, and he was able to do that for several years. However, he does have some side effects of chemotherapy, including he has like a lot of like dental problems just from all of the treatment and dry mouth and all of that. That's a big thing that affects him. He also sees cardiology because he has a lot of problems with hypertension, and just his heart rate is just too high. Psychologically, it's definitely affected him. You know, Robert and I we're no longer together, but he kept a lot of the grief inside, I think, and didn't really talk to me about it because he didn't want to make me upset. I was already upset enough. And so it really made it hard for him. And there's a lot of things that he still is like dealing with. Robert's also a veteran. So, I mean, it's kind of one of those things, you know, did he have depression and anxiety? And is all of his PTSD from being a veteran or from DSRCT or maybe both together? So it's just something to think about. And then the other thing that helped with Robert, or the other thing that happened in July of 2023, Robert was diagnosed with neuromyelitis optica. That is considered the sister disease of MS, and it affects mobility exactly the same way, but it also can affect eyesight. So Robert now is disabled. He is unable to work at all. Sometimes he has to use an assistive device to walk around, like a cane or a walker. He is on very high doses of like gabapentin and things like that to help with nerve pain, and high doses of steroids. So that is a big diagnosis that came after the DSRCT. Do I know that it's related? Absolutely not. But I think it's important to know that like things are different afterward. And then finally, I did want to talk about myself because that's who I know the best, right? So I'm 38. I'll be 39 this year. I really struggled a lot when Robert was diagnosed. Like I had such severe anxiety and agoraphobia. I was 25 when he was diagnosed, newly pregnant with Josiah. And so I felt like the rug had been ripped out from underneath me. I was supposed to have 40, 50, 60 years with this man. And they told me like, that's not happening. So there was a lot of grief and anxiety because I was like, well, I'm going to try like hell to make that not happen. And so I had, you know, a lot of depression, just really a lot of anxiety about like not having control, because it was the first time in my life as a younger adult, like realizing that you really don't have any control. You think you do, but truly, like in the whole world, you don't have any. And it was a huge eye opener for me. And as a caregiver and being a nurse, it was extremely difficult to kind of go from one to the other and not always be a nurse, but be like a girlfriend. And that ultimately is why Robert and I are not together anymore, because I couldn't turn it off. And Robert and I co-parent beautifully. I mean, if I called him right now, he would do whatever he needed to do for our kids. And he is such a great dad. But I just couldn't turn that part off. And especially when he was diagnosed with the neuromyelitis optica, it was really difficult for me not to be like, okay, I'll be at the hospital. What do you need me to do? How can I help you? I had a different partner. And so it's very difficult to be like, my wife now, she was like, what do you mean you're going to go clean Robert's house? You know, but I'm like, well, he needs me to do it. So I'm going to do it. So that has made things, you know, difficult to kind of have that boundary. And honestly, for people that caregive that are partners, like I have so much respect and really no advice, because I couldn't ever figure out how to make it balanced. It's so hard. And so I just really, my hat goes off to people that are able to do that. And really, like, being a caregiver has been in like my bones for a long time. It's just that I wish that for the sake of mine and Robert's relationship, and, you know, for my kids to have their parents together, that I could have switched it up. It is very difficult. So that, Laura, that covers like pretty much the whole disease timeline and stuff. Do you want to, I don't know if anybody has any questions about that, but then I was also talk about palliative care.
Looks like we have Joe is with us, who has a question. So let's go ahead and do a few questions about your timeline story, and then we'll switch gears. Joe, go ahead.
Yeah, I just had a quick question for you. So obviously, you mentioned that he had the reoccurrence. You guys went through, did some additional chemo, and then the high surgery. Obviously, I know that you had mentioned that there was some extreme difficulty as far as, it seemed like he was kind of running out of gas, so to speak, after the radiation. My question to you is, after he had the reoccurrence, I mean, I think I can speak. I've had a couple reoccurrences now. I'm back to NED. How did you guys make the decision to stop treatment? Was that something that the oncologist had recommended? Was it that he had just taken on too much at that point and you needed to stop and then just call it test the waters? Like, how did that decision kind of flush out for you guys?
After the whole abdominal radiation, is that what you mean? Yeah,
basically, like what was the final point of treatment, and was there any concern about not continuing on some form of maintenance? And what was that decision like to go and say, okay, we're done with treatment and we're just going to wait and see what happens from here forward?
Yeah. So after whole abdominal radiation, I mean, I think that it's a good point at that point, especially like to kind of reevaluate kind of how things are going, if we need to change anything. And so he finished his whole abdominal radiation. He was a couple sessions short of like his planned treatment. And then we rescanned in 3 months. But part of the issue is that we were kind of going through a transition with oncologists at the time. Since we live in Southern Missouri, it's difficult. There's not a lot of like healthcare around here. And so our oncologist that lived in the town that we lived in actually moved. And they had locum coming in. Locum was not as comfortable really communicating with Pete. And so really we kind of were forced to like pause, you know what I mean? That's essentially what happened. And thank goodness he came back NED, because if he wouldn't have, then we would have been back on treatment. But then, we did the serial every 3 months times, 2 years or whatever it is, then every 6, then all of that. And he's been clear since. And we've gotten really lucky in that sense. But yeah, it was just that natural like pause. And then we scanned, and then they were like, well, we don't need to do any more treatment.
Okay, thank you. Appreciate it.
Yeah, absolutely. Any other questions?
Chelsea, I know it's a long time ago, but just, do you remember when he was initially diagnosed, what the burden of disease was? Liver involvement, solely abdominal, or was it this, I think people ask me more just because as a nurse, probably take the bigger picture, but ultimately people say, oh, he had this watermelon or softball inside him. But I assume it was more than just a tumor.
So he had a 12-centimeter tumor that sat right around his stomach, like his literal like organ stomach. And it was in the soft tissue, like peritoneum area, right? So that envelope that encases your entire abdominal cavity, that's where it was. And then when they opened him up and looked at the peritoneum, it was just tons of different like little dots of cancer that they could not get out because it was innumerable, meaning so many that they just couldn't. But he didn't have any liver involvement. We were really blessed that he didn't have any like above the diaphragm involvement as well. It was just, he had that big one in the middle of his belly, about the size of a softball. And then later on, he did have a smaller one in his pelvis, like lower in his pelvis, that they resected during HIPEC. But he had like his omentum out. So like that bag that like wraps up your intestines and all of that, they took that out. His peritoneum, like they went through and excised everything that they could and cut out big chunks of what they couldn't and did the best that they could. and then washed him out with chemo. Does that help?
Well, and just for context
Yeah.
too, because I think some of the modern patients don't know what it was like in 2012, right? So
Yeah.
in 2012, we didn't have this diagnosis differential of liver, like whether you have liver involvement or whether you don't, like changes the whole game. That wasn't a thing then. Also, a lot of times people very often, when they got diagnosed and their scan showed a large tumor in the abdomen, their local hospital went in and resected it. And then the pathology that came back from it is what gave them their diagnosis. And so that it didn't necessarily like they found it and then treated it and then got to surgery. A lot of people got surgery and figured out what it was. And that's when the doctors realized, oh, we probably didn't get it all, right? Or some didn't realize that. And then so for in Chelsea's case, right, like they went in, they removed it, what they could, what they thought they were going to remove, but there was way more. Maybe Chelsea, you could also speak to, so then you did treatment, but you did have progression later. So talk about where it came back when it did.
It came back in the same area in the abdomen, and the soft tissues there. And I mean, I didn't obviously see, but I believe it was the peritoneum. The thing about Robert's tumor is that, so we didn't get to do a PET scan for the big tumor, right? Because we were like, oh, we need to yank that guy out. So when we went and got a PET scan, nothing lit up. It did not light up at all. And so we really, all of our treatment was CT driven. And so it's hard to kind of know exactly what's there, right? Because the PET is just like so great at like catching every little like flare, but CT is not as advanced. And so there could have been tumors that we didn't even know about, that just were not picking up on the CT. But yeah, treatment is a lot different because the guidance now is like, if there's something going on, like you don't just go in and take it out. Like you got to figure out what's happening first. So it's been a big change.
And when was his PET? Sorry.
So he had a PET in the beginning and it never lit up anything. Like he had, and I know because the surgeon saw like innumerable studying on his peritoneum and it never showed. Which I never really understood that. And he had to have so many CTs and he hated it.
I think one of the things that I learned in my time, and I think a hard reality of this, is that they really rely very heavily on imaging to determine everything. Imaging is not imperfect or not perfect.
Right.
It's not, it's a picture. It's not an everything. So that's why I think the importance of the things that are happening now, like the tumor screening in the blood and things like that, I think are really important. And having just awareness that of the way the scans actually work, which is not a clear 100% picture of exactly what's going on inside, which is something they can only see by going in.
And treatment is different too. You know, like everybody did P6 and that was pretty much it. But now they have so many immunotherapies or targeted drugs. And I mean, it's just so much different. They didn't even, Robert's tumor was never like, they never did any of the genetic testing that they do now. Like that wasn't a thing that they did. And so it's a lot different now. And there are a lot more, I feel, lines of treatment that you can do in order to, see if you can get a response.
Just for context, immunotherapies have only been around for like the last 10 years, and full molecular genetic arrays that we're seeing on tumors, that's like in the last 5 years. It's not really something that we had access to in our journey. And that's part of why I shared that whole narrative explaining precision medicine to you guys, because precision medicine isn't something that existed for my son or for Robert. It is literally the most cutting edge way of treating cancer by utilizing stuff that really this is data they didn't have 10 years ago. So do you think we should switch gears and go ahead and talk about palliative care and symptom management?
Yeah.
All right.
Yeah, I am. And we can take more questions in a little bit.
Awesome.
This part will not be as long as it was before, I promise. So, as I said before, I've been a nurse since 2011, done a lot of things in nursing, and this entire journey is really kind of led me to really wanting to do palliative care. And part of the reason that I wanted to do palliative care is because I think it's important to look at patients as whole people and not just a set of symptoms or a diagnosis. So palliative care can be kind of a hot button issue, and I can understand why. I think our current model of medicine really lumps palliative care and dying care together, but they are not always together. They do not have to be. They can be definitely separate. So palliative care, which is what I do, I work in the hospital. So I see patients that are inpatient and admitted with serious illnesses to really do symptom management and to talk about their goals. That's all I do. So palliative care is for people living with a serious illness. So cancer, of course, qualifies. Congestive heart failure qualifies. There's lots of them, COPD, things like that. Those are all serious illnesses that kind of change everything about the way you're kind of functioning as a person and as a family with like the support people around you. So the palliative care team, and that's the most important part, is that it's a team approach. It usually consists of a provider. Sometimes it's a mid-level, like an NP or a PA, but there also will be a physician sometimes. It just depends on the program. There's specially trained nurses, social workers, chaplains, music therapy. I mean, like, there's all kinds of things that we can do with palliative care. And the whole point of palliative care is to add an extra layer of support on top of what you're already having. So with our oncology patients, they already have their oncology team, and they love their oncology team usually. But the nice thing about palliative care is that you don't have to stop seeing that team. We're coming in on top of that team and helping. So your symptoms like extreme bone pain, that your oncologist is really having a hard time figuring out the right solution, that's right up the alley of palliative care. We do a lot of symptom management. So the symptoms that we manage include all the symptoms that you would have from like chemotherapy, including, pain, nausea, vomiting, diarrhea, constipation, difficulty sleeping, depression, anxiety, shortness of breath. All of those are things that we can help manage. And it's more, and like I said, it's a team approach. It's not like we're going to do this and we're going to kick them off the care team. It's not like that at all. I feel like we're just trying to improve symptoms to improve quality of life. Because as I know from Robert having cancer, it's really difficult to do the things that you want to do, because you just feel like crap. So if you feel like crap and you're so exhausted and you have like that cancer fatigue, then we're there, palliative care is there to kind of say like, well, let's try this and like this, because they give stimulants for cancer fatigue. So let's try this stimulant, see if it helps. If it doesn't, we'll try another one. And if that doesn't work, we'll try another one. Like, we're constantly going down the road of trying to find things to help you do the things that you want to do. So Laura had shared with me that Cole was really active. And so part of palliative care for like super active and people that want to go is making sure they can go if they want to go, instead of saying, no, you have to stay at home, you're going to miss out. So really working with the team in order to do physical therapy, occupational therapy. If eating by mouth is really important to you, but you have such a sore throat that you just can't because you just are hurting everywhere, everything hurts, you have really bad thrush, we're going to figure it out, because that's the most important thing. The other part that we do is advanced care planning. So advanced care planning is just an easy way of saying, what are the things that you want to do? Like, reflect on that. What are the things that you want to do? So I have people tell me that they want to make it to graduation, right? Graduation's coming up. They want to make it to graduation. Okay. So you want to be able to go to graduation with your own 2 feet somehow and make it there and watch. And we try to create a plan around getting you there. Another good example is if you want to be able to go to the park with your kids. Like when my kids were little, Robert would want to take them to the park. Well, I mean, that's a lot to think about, and like trying to walk on uneven surfaces and feeling so freaking tired, and not being able to keep up with the kids, and kind of helping you kind of settle into like a more reasonable normal, right? Because you're not going to be able to do that all the time, but while also supporting your symptoms, like your pain that's keeping you at home in bed, or the fact that you can't leave your house because you just have such severe diarrhea that like you can't go anywhere. Those kinds of things are things that we really help with. And that's part of the reason that I love my job so much, because I feel like nurses are specifically well positioned to do this job, because a physician a lot of times will walk in the room with you and say, okay, this is what we're doing. And you're like, oh, okay. I mean, that's what you said, like, that's what we're doing. But a nurse, I feel, will say, well, what do you want to do? Like, what is your goal? Is this even something that you want to do? And giving people the option to do, this or this. Like, I think that that's really important. And I think that as a nurse, that's really one of my superpowers, is that I get to have real conversations with people about their health, and help them really understand things like treatment options, or understand their goals and how we can help them. The other thing that I really would like to talk about, and this is the last thing that I do want to talk about, and then you guys can ask questions, is that I know that when you are fighting DSRCT, or your loved one is fighting DSRCT, I know that sometimes it can be really scary to talk about what happens if the treatment becomes too much, or what happens if I go into the hospital with sepsis. I really want to really ask you guys to think seriously about naming somebody to help you with healthcare decisions if you're unable to do that yourself. And in some states, there's 4 actually in the United States, for those of you that are in the US, there is no next of kin hierarchy, meaning that if you're married, your spouse is, it doesn't matter, what they want individually, everybody has to make a decision together. So like, let's say because I live in Missouri, and Missouri is not a next of kin state, and there are 3 others that are not. Let's say I end up in the hospital and my wife is there. My wife is not my automatic decision maker here in Missouri, which is wild, because you just have people coming out of the woodwork or that don't know you as well. And so making sure that you get that down is so important. And making sure that you have real honest conversations with your loved ones about what it is you would want and what it is you would not want is really important, because not giving guidance to your loved ones about what you want is like something that they will think about for the rest of their life, because they will not know, had you been able to make the decision yourself, how you would have chosen if you don't tell them. It's not like, you know, oh yeah, they would want X, Y, or Z. You have to ask, because every situation's different. And studies show that if you have those conversations with your loved ones and let them know, like, I would never want to be on dialysis, for example, and they know that that's a hard line, then that gives them so much more peace instead of having to guess. And there's a lot less kind of like grief responses, and it decreases the emotional burden on the family. If you can really have an honest conversation, and you don't even have to start off like very serious, right? You can just say like, hey, if there comes a time where I am not able to come home to my home, that makes me concerned about the future. You know, like if I have to go to a facility and live there maybe forever, like we need to talk about what that looks like. And I know that it's not a popular thing to talk about, but it is so important, because I have sat bedside with families who had no idea, and they'd constantly question, am I making the right decision? And so if you have those things, you have a trusted healthcare decision maker, and you also have those things written down. Those are two very, very important things to have, so that number one, there will be less emotional burden if something were to happen. But number two, at least your wishes will be known, and we can do things for you instead of to you. So that is my palliative care spiel. Most, big hospitals will have palliative care teams. So you definitely need to talk with your oncologist about getting involved with the palliative care team. We see peds, obviously at a peds hospital, they're so excellent. They have child life, they have, behavioral therapists, they have all of these things, but just make sure that you definitely consider getting involved with them, because they really just want to help you like live in the best way that you can.
Thank you, Chelsea. And a follow-up question, and if this is, hopefully this isn't too hard of a question. Were you guys, because of your medical knowledge, do you feel like you and Robert were able to have those conversations in the time that he was really struggling?
No. I think that Robert didn't want to think about what could happen. And while I can understand that, I think that had I have had to make some really hard decisions, I do think that that would further traumatize me, just because you can't always tell exactly what somebody else is going to say unless they tell you themselves. And Robert was when he was really in treatment and very sick, he was very avoidant to talk about that kind of stuff. It was always like, well, we're going to get through today and it's going to be great. And I like the whole time I like crying, and like, because I'm working a million hours and have kids and stuff, but he never really wanted to disappoint me. And I mean, I'm lucky that like it never came to that, but I wish that he would have talked to me about that, because, I just really would want to choose what he would want instead of what I want or what I think is best for him. And it makes it complicated when you're a medical person, because you're like, well, I know what we should do, but it's different when it's your family.
Thank you. And I just want to kind of throw in there as well. So she mentioned palliative care was a part of our journey for Cole. We were introduced to an amazing palliative care team after Cole's very complicated liver surgery in Charlotte. But at that point, he had multiple ostomy bags. He had TPN for nutrition. He had a lot of stuff going on. And the oncology team's focus is your cancer. So they're there to treat your cancer. The palliative care team for us was there to help us live daily. And Cole, like she said, Cole wanted to be active. So a big challenge for us once he had the ostomies was just keeping bags on. Like every time we tried to go somewhere, we literally, I have a post that comes up in my memories every year that we set a record. We made it through a whole movie without a bag leak because we couldn't go anywhere without his bag starting to leak. But with the help of that team, I learned I'm like a full wound care nurse at this point. Like we got the right supplies and the right things and found what worked for him, that we were able to manage that in a better way and travel and go out, and he could do things without fear of his bag dumping all over his lap at any moment. Right. Also for us, they were able to help him keep him mobile with his PT and OT. But the most important thing was that they were the ones that were sitting down talking to Cole during that time and saying, like, what do you want your life to look like? And then that was their objective, not whether or not you're going to beat cancer, but like, what do you want your life to look like? And I don't think that is more important than the other. I think for us, it was valuable to have both.
But yeah, I think that, and like I said, doctors are all the time like, well, this is what we're going to do. And they might say that about your cancer, right? Well, we're going to do X, Y, and Z. And we're asking, like, what do you want to do? Like, what's your plan? Like, what's important to you? So I think that really is a different perspective and something that I think is really important. And then, we really work hard to coordinate care and try to like, okay, so this isn't like you need help with X, Y, or Z, like, and that's not helping. Well, I guess we're going to do it and we'll step in and send a referral or figure it out, because we recognize the burden of living with a serious illness, but that doesn't have to be everything. Like, that's not what everything is about, right? You still have to continue living. And I think that it's important also to know that, like, palliative care is also concerned about the caregiver, which I think is important, really understanding the burden of the caregiver. And we don't always do the best job of it, but really trying to understand, like, well, they have 4 appointments this week. Like, how can we make this easier, or whatever it is, just to try to help.
And one other thing too, I think that we got out of palliative care team, the clinician specifically was able to look at all of the medications, because if you go through the process, right, you start out and you're taking this for this and this for this, and then like within a couple of years, you're like on all of these extra medications for different symptoms. And they can really kind of step back and look at, like, well, these might be causing some interactions that are causing this. So let's adjust some of these meds. So like, it's just another set of eyes on those symptoms that maybe the oncologists just don't have time to really invest in the research of how to treat your bone pain when they're worried about your next scan. So that's someone who can help with that. I think, Joe, you had your hand up first.